that was just a great overview, and I think we've all learned a lot, and I actually understood most of what he was saying, which is probably a good testament or something. So now we're going to talk about some specific pieces. And as we said, when we were starting to talk about what to showcase, we could go in 15 different directions. But we felt there were really two areas that we wanted to highlight that it was important for people in the upstate to know about. And the first was advances and changes in care process. So I'm going to call Jim Shew with Blue Cross Blue Shield. Jim has been he's a board member of 10 at the Top, and Blue Cross has been a great supporter of our organization since the beginning, and a great supporter of the upstate and all of South Carolina. And Jim is going to lead a panel. If the panelists would go ahead up as Jim comes up, then we'll get started.
I'm Jim Shew with Blue Cross and Blue Shield of South Carolina. I want to recognize our panelists and thank you very much for being here today. Dr. Sinopoli with GHS, Dr. Saccocio with Montessori St. Francis, Dr. Eisenhower with South Regional. I can't really see Howard Einstein up there. Howard Einstein with Rosenthal Einstein. We have a really interesting topic, I think. I want to, by way of background, let me describe a little bit about advances and changes in the care process. I think what we're really talking about is how is the delivery of medical care changing? And I really think the measure that we want to use for improvements in medical care is sort of the test of the triple aim. Triple aim is a term that former director of CMS, Donald Berwick, coined. And essentially it means any improvement in healthcare should lead to better outcomes, lower costs, and improved patient satisfaction. And those are the standards by which we want to measure changes in healthcare as they improve the system that we have today. So we're going to go through some of the recent advances in the care process using that standard and just talk a little bit about how they've affected the patient, what the expectations are in the future as well for several of these topics. And the piece that I want to get started with is something that I think maybe many of us are familiar with, but maybe not all. I'll give just a real brief statement on value-based reimbursements. So what we're essentially talking about here is after the passage of the Affordable Care Act, there was the introduction of what were known as the Pioneer ACO models. And it was a way for health systems and providers to be reimbursed through the Medicare system by a manner other than strictly fee-for-service. They were reimbursed based on the quality of outcome and the cost that they're essentially received a fixed payment to cover the full cost of services that were provided. That model was essentially built to help offset some of the Medicare cutbacks that were also part of the Affordable Care Act. And that system, which rewarded better outcomes, has been something that has shifted sort of the model for both public and private healthcare financing. And it's, of course, a very complex issue because there are a lot of changes and unintended consequences, I think, that may go along with shifts in the way in which healthcare is financed. So I want to start out a little bit today by going to our panel. I'm going to start with Dr. Eisenhower. And I just asked about this particular question, value-based reimbursements, and how might such a model work successfully that could allow physicians and hospitals to be rewarded for better care or potentially even penalized for poor outcomes. What would such a model look like, and how could it potentially be implemented with the healthcare system here in the upstate? So Dr. Eisenhower.
Hey, I'd like to understand who the audience is a little bit better here so we know who and how to think about things. How many in the room are licensed professionals within healthcare? Doctors, nurses, therapists, that sort of thing. All right. How many of you use healthcare? All right. How many of you pay for healthcare? All right. So got a lot of hands up on that. Anybody not raise a hand on that? Okay. So doctors don't think any differently than anybody else about their job. I would propose that you care about your income. And you care about how much time your job takes. In other words, how much time are you away from your family? How much time do you get on vacation? And you probably care about the quality of your work, which might mean how good your output is or how interesting your workplace is. Doctors are the same. There's nothing different about that. And so whenever we talk about payment reform, we have to couch it in a way that doctors understand. Is it going to help something? Is it going to cost me income, but is it going to give me back time? Is it going to improve the quality of patient care? these things, the same things that you would like to know about a change that comes up. So now, one thing I want to get across here early is that most of what happens in medicine is pretty good. You know, people come to the U.S. to get their medical care. So we're talking about adjustments at the edge, things that need to get fixed for sure, things that are inflationary for sure. But by and large, what we have is delivered very high quality medical care. Right? So what kind of things do we need to try to build into a structure that we fix? Well, number one, we need to realize that how doctors are currently paid generally, the fee-for-service model, is that doctors sell relative value units or RVUs worth of work to an insurer or to an employer, and the more they do, the more RVUs they generate, the more they get paid. And so if some work you ask a doctor to do doesn't have an RVU attached to it, it's on the house. And so no matter what your ethic is, if you tell me that I want you to do this, but I pay you to do that, what ultimately is likely to happen? Right? So our payment models have to do as they are doing now, shift from fee for service over to some portion of the money to the providers being fee for other things, or payment for other things, quality points. And I would suggest to you that if we're going to build a model like that, the component that is not due to the work done must really address a couple of things. It must address providers' attention to safety of care transitions. What's a care transition? Well, it's when things change. It's pretty stable at home, right? But how about when you come home from the hospital? Have you ever been to the doctor's office whenever you were given an explanation about what was wrong with you, what you need to take for medicine, and you get home to talk to your spouse and you really cannot describe what you were just told? Ever happened to you? No hands up. I'm sure I see some heads nodding there. That's a problem with care transition. We don't do that very well. And the symptom of that is readmissions to the hospital. Certain diseases have that all the time. Chronic diseases like heart failure are particularly susceptible to that. So we should reward behavior that encourages, that improves care transitions. By the way, this is not all doctor work. These new things that we ask are of other people. We need everyone in the scheme to practice to the top of his or her licensure. We need health workers, nurses, other care coordinators, but ultimately, someone's responsible for the care of that patient, so the doctor sees some piece of this. Another thing we have to be looking for that we've not paid much attention to is barriers to care. What's a barrier to care? Well, if you don't have enough money to pay the lights, put food on the table, and get your kids to school, and you need to buy your medicine, what's a good parent to do? Sacrifice something? Probably not going to be the kid at school, so you may not get your medicine filled. This happens all the time to people. And if you have a moment, I'll tell you a story. We had an employee about 2.5 years ago who was admitted to the hospital for out-of-control diabetes. It's on the hospital's insurance program. Turns out he wears an insulin pump, and the insulin pump requires a concentrated form of insulin that cost him a copay of more than $100 a bottle, and he needed 2 bottles in a month. He didn't have the disposable cash, so made 1 bottle do. And he wound up in the hospital, harmed kidneys, he's had open heart surgery, a lot of things associated with his diabetes. He had made decisions about care expenses that drove behavior that came out bad for us financially. So that's a barrier to care from someone that we actually employ at the hospital. How about someone who's unemployed or who lives in a food desert or who has no transportation? That's one of our big problems, Norton, in the state. Talked about behavioral health. It's number 2 would probably transportation inadequacy, moving around when you don't own your own vehicle. So we have to reward doctors who are conscious of and participate in the discussions that help discover and cure the barriers to care. Social agenda perhaps, but if you want to get somebody to the lab to have their blood drawn, they need to know where it is and how to get there. We're responsible for such things. And finally, we have to be aware of duplications and omissions of care. And that comes under the rubric of coordination of care. We do a lot of tests, we do a lot of things because we're not sure they've already been done. We don't have access to them. What does it take? It takes somebody looking to see what's been done. That takes time, that's a non-doctor skill, it's a delegatable task to the other people who help make care safe in the country. It also, it helps to make sure that we don't miss things, it helps to make sure that we don't duplicate things, helps to make sure things are lined up for efficient visits to the doctor's office when that time comes. So again, as we move from fee-for-service, we need to award these 3 things: transitions, barriers, and coordinations of care. I'll hand it over.
And I as follow-up to that, I'm going to go to maybe Dr. Sinopoli. So I really like the point, Dr. Eisenhower, that you brought up, that you're moving to a model where you're going to ask for potentially uncompensated, resource-based relative value units. So in the market that we're in today, how do you get providers, doctors, I guess in particular, interested in participating in what would amount to a complex reimbursement arrangement when they all essentially are, it's hard to get in there to see them today, long appointment times, they're busy. What is the key to bring doctors into this fold and have them be interested in participating?
So I think that, as I've talked to physicians, the main thing that they're interested in is getting back to the actual practice of medicine. If you talk to most doctors now, they spend an inordinate amount of time doing paperwork, filing claims, following up on claims, doing administrative things, seeing patients, watching patients have poor outcomes because they don't have enough time to spend. So they're spending very little time in the exam room seeing patients. And so I think what's attractive to physicians about alternative payment models, if it's purely just a different way of getting paid, it's not necessarily helpful. But if it's a different way of getting paid within a system that then helps support you with care management processes, with data, with report cards, with the ability to actually see how well your patients are doing, and then to be able to actually have somebody, as David mentioned, a nurse care manager or social worker actually intervene on that patient for you in between visits. And so you're focused on the patients in the exam room and what you're doing, you're actually making a difference. And you're actually providing what all of us went into medical school for, is to provide that kind of quality of care, and you've got the help and support to do that. So it's not, and the issues with the Affordable Care Act is that insurance change, it can't just be about insurance change. The insurance change has to support a very different care model, to David's point. So both of those have to go hand in hand, and if they do, the doctors will be eager to participate in that.
Follow the Dr. Saccocio. So value-based contracting, does it make it easier for us potentially to recruit providers, high-quality providers into the upstate to work at major health systems like Saccocio?
Absolutely, and I believe we're going to see more of that as time goes on. Much like you, when you finished your education or your training, you had big dreams and ideas. New physicians have the same. And 10 years ago, 7 years ago even, success was equated to the number of patients that come into your office and the number of bills you submitted to the insurance company. And now that model's changing. 5 years ago, residents new out of training were choosing health systems to be employed if they had an ideal electronic health record, if they had the tools to help them be successful in their job. 3 years ago, physicians were looking for health systems that provided a patient-centered medical home resource or network, again, to ensure their success in taking good care of their patients and having the resources available. And as we look at today and the information that is available to you, to me, and everyone else, if you go to hospitalcompare.org, you can identify the level of quality, patient safety, process measures that are in place, and even now the Medicare spend per beneficiary for each patient at that hospital. And that information has been useful for physicians because they wanted to make sure that when they did send their patients to this hospital, that they received high quality care at the best cost and a patient experience that they would appreciate. And today, physicians are now on that same lens, that same microscope under physiciancompare.gov. Now every physician across the country will be measured by their quality, the patient experience they deliver to patients, and their healthcare spend and how it impacts the rest of us. So physicians, again, have those big dreams and big ideas to find that partnership, to provide those resources to their patients, to ensure they have high quality care to deliver, a good experience at the right price. And when you consider that in the upstate, we have nationally recognized health systems that provide this type of care, this is the place where physicians want to provide care, where nurse practitioners and physician assistants want to work.
So let's shift gears and talk a little bit about the employer perspective on this topic. Howard, I know you work with a lot of major employers here in the upstate, and I'm sure they have a lot of questions about paying for healthcare under this model. Is it going to work? Is it going to be effective? And do you think, from an employer perspective, the upstate is somewhere where value-based programs for medical care can work?
Well, employers want everything now, so it's a complex topic. So a couple things here in the other panel members. Medicare and Medicaid are a different animal regarding when you hear about ACOs and management or looking at outcomes-based medicine. So when I look at Greenville, particularly the upstate of South Carolina, we have a big tax base. We have a lot of private employers and a lot of government, military, universities. So we got a lot of private employers. And typically the ACO model that you hear a lot about in healthcare reform doesn't impact the private employer market yet. You know, if you work at a company of 500 people and doctors are paid based on outcomes of those people, they're just going to quit taking your sick people. So their outcomes are better. So with Medicare, they get a population of 10,000, 20,000. They can't pick their customers. They're all over 65, or they're Medicaid, and they're all, you know, income based. And so it's an easier population to manage because they can't pick and cherry pick what they want. So in the employer-based model, it's a little bit different. Where we see value-based plan design, maybe a term that we use with employers, Angelo and I've had some discussions about this, is where an employer might take, with data, and we talked about data a lot, which drives a lot of decisions today for employers, where they'll take, they've got 200, you know, orthopedic surgeries, back, neck, spine, knees, joints, those types of things, and they actually can go and negotiate with the providers because they own most of the hospitals own most of the doctors, and they can negotiate for bundled pricing for those things, whether it's anesthesiology, radiology, pathology, inpatient, and get a flat fee price and negotiate with providers. And what the employers can do with value-based plan design is they can say, hey, if you go to this facility, we get a cheaper price for a knee, and we'll waive your out-of-pockets, we'll waive your deductibles. So they can drive consumers to those places. With the data, you can negotiate. So a little bit different, and I think where value-based plan design is going today, than maybe the discussion, similar to what ACOs are doing, a little bit different in the employer market. Discussion's a little bit different. But I do think there's a place for it, and I think it's growing.
So let's go on to the next topic. I want to just read a couple of statistics. I'm sure many of you are familiar with the topic of specialty medications, really high-cost prescription drugs. In 2014, U.S. prescription drug spend increased 13.1%, and that was the largest annual increase since 2003. And at the same time, spend for what we call traditional medications were basically flat. Drugs classified as specialty prescriptions had a cost increase of 31%, and specialty drugs now drive roughly 1/3 of all drug spend in the United States, while only accounting for 1% of all prescriptions. So these are really high-cost medications. And we now see pharmaceutical manufacturers are focused on the development of these complex, high-cost specialty medications that are going to treat a very small portion of the population and therefore going to be managed very differently. I'm going to start with, go back to Howard. You ended the last topic. I'm going to start with him here. Howard, the new specialty medications obviously provide great benefit to individuals who use them, but you know they have an extreme high cost. When I say extreme, I should say, you know, we're talking about annually 6 figures per patient in many cases for drugs like the Hepatitis C medications that you probably read about hitting the market. Howard, I guess sort of a broad question: how sustainable is that in the employer market long term, and you know what do we see employers doing to try to address that?
It's a big problem, and it's probably, we're seeing drug spend increasing for employers of less than 500 people, probably doubling in the last 12 months. And it just takes 1 or 2 members to drive that cost. We've got a client now that's got $516,000 a year on a 38-year-old person. They'll take that drug the rest of their life. And so we've got drugs that they're going to put people out of business, and it's a problem. And the question is, do employers? You can't manage your drug spend for a new drug that comes out that helps somebody live their normal life in a pain-free environment, able to move forward when there are no other drugs on the market, there's no generics, and there's nobody else doing any research for that condition. And so the Hep C discussion is really, that brought it to light last year when there's a test now that you can do, keeping it general, that, you know, you can go and see if you potentially are at risk for Hep C, and, you know, it costs $140,000 for 3 months, and you got a 95% cure rate. Chances that you get Hep C while you're in your working life are slim to none. And that means that you're not going to get it. You get it later during your Medicare, and then that's obviously gets into transplants and all the things that comes with it. But the problem is that the employers are funding the cure for Hep C in a very narrow window. And when you get some guy that's getting $140,000 in drugs for 3 months, and you get 1 or 2 of those, it's going to kill the drug spending. And we're running into these other drugs that are 300,000, 400,000, 500,000, and so it's not sustainable. So the question is, do you not cover those drugs? Because it'll put an employer out of business, and if you're self-funded, you have that option. And what kind of message is that back to that employee? And it's creating some really strange discussions right now with employers when you've got people whose, you know, their costs are up 30, 40% overall because of 2 and 3 drugs for a couple of members. So I don't think it's sustainable, but I don't really answer it.
Yeah, well, let me follow up with, I'm actually going to go to Dr. Sinopoli. You kind of touched on a topic that maybe we might save a little bit for our next panel, but you were sort of referencing what I would call the field of personalized medicine, which is using an individual's genetic information to help guide treatment decisions, hopefully making sure you're targeting the right drug to the right individual. And Dr. Sinopoli, could personalized medicine help manage the cost of specialty drugs? I know GHS is really involved with a lot of research right now in that area.
Yes, I think ultimately that's going to be the direction where things will need to move. And so genetic testing or other types of testing that can predict whether a particular drug will be effective for a particular condition. And therefore, using these very expensive drugs in patients that ultimately don't get any benefit from it, hopefully we'll be able to weed some of that out and not expose people to that expense when we can determine ahead of time that it's not going to be effective. It's still in that stage right now, though, of going through all this. It's an evolution, it's an early phase, and trying to figure out what biomarkers actually predict whether a drug will work or not. And that's not to the stage it needs to be. So there's still a lot of questioning out there, a lot of research that needs to be done, a lot of documentation that needs to be done, and then the testing itself. You know, who needs to get the testing, and what level of testing, and do you test everybody for certain conditions? And if they find out they're predisposed to have some condition going forward in the future, what do they do about it? Is there anything they can do about it? So what's the cost of the test worth it to begin with? And then does it predispose them to testing after that might not would have otherwise have gotten, that then predisposes them to some complication? And so it's a very complicated area, and I think that is going to be the future, trying to figure out from a genetic standpoint or other biomarker standpoint, what people are at risk for, how to treat them best, what drugs are most appropriate.
So, Dr. Saccocio, you know, whenever the high-cost brand drugs were $100, you know, there was sort of a strategy that a lot of insurance companies used around increasing the copay, maybe changing co-insurance, and that was the strategy for managing drug costs. You know, we're talking about drugs that cost 6 figures annually. What are the things that we can do to better manage costs for specialty medications, while still, I think it's very important to say, allowing them to benefit patients, and also not discouraging innovation? Obviously, innovation is the key to improved health.
Well, there are 2 perspectives when you look at specialty medications and what's appropriate and how do we best manage. And I'll start with the clinical side. Consider patient Peggy. Peggy's 45 years old, is diagnosed with breast cancer. She goes to see the oncologist and asks the oncologist, Dr. Smith, what is the best thing for me? What will save my life? And if Dr. Smith said, well, here's this medication that costs $100,000. Here's medication B that costs $20,000. And medication C that costs $15,000. Which medication do you think Peggy will choose? Yes. So now let's consider the evidence. And when you look at data that is available to us now like never before, we have the capability to look at clinical trials, chemotherapy protocols, to determine what is the best regimen for Peggy that will save her life. And the news is it's not necessarily the $100,000 regimen. It may be in some cases, and in that case it is hard to put a price tag on a life, but it gives us an opportunity to think about how we manage differently. So we'll be with data, clinically speaking. Financially, we have some alternatives. When you think about regulation, some folks are for additional regulation and others are not. We heard from Jordan earlier today that in other developed countries, there is definitely more regulation. Regulation has helped keep the price of these drugs down in other countries, and we choose to have more selection and more independence, so that's a price we pay. On the other hand, when you look at these specialty medications, you cannot go to CVS, you cannot go to Walgreens necessarily to pick up a specialty medication that costs in the 6 figures. Only specialty pharmacies that get additional privilege are allowed to dispense these medications. So what do you think happens when it turns through another system to the cost of these medications? It's additional cost to the system. Granted, you could say that's free enterprise, and I applaud those efforts. So what I would encourage us to do is to increase free enterprise and develop more competition. I'll give an example of McKesson Pharmaceuticals. There are many medications that only McKesson provides. What do you think they do with the price? Because they have the leverage. Just like you would do with your business if you were the only supplier and there was a high demand. So I think we have to keep that in mind whenever we look at the information. It's the data that's available, and let's make a logical decision, and let's also be reasonable with our competition and our ability to sell.
So, Dr. Eisenhower, a lot of, I think, interesting points to follow up on there. Competition, regulation, using data. What is the opportunity for the cost of specialty medications to be reduced over time? You know, I guess we're sort of away from the time period where brand drugs go to generic, but is there some opportunity to follow the, you know, say the way that consumer electronics often go over time to see a reduction in cost? Is that a possibility?
I don't have much hope for it. I mean, maybe a 10 or 15% reduction due to generics, but the problem is they're complex drugs to manufacture. And so the manufacturing cost is going to be recovered. What we've seen in generics, at least in certain cases now, has been a rebound in price. So the drug goes off patent, and the generic manufacturers take it up. The price is a lot lower than it was before, so many generic manufacturers drop out, and you're left with the sole supplier. And then suddenly the drug runs out for a while, and there's a shortage, and speculators step in, and the price goes way back up, and guess what? The drug becomes available again. It plays over and over. Typically, in the U.S., there's somewhere around 200 to 250 drugs that are on shortage. FDA reports that annually. That's up from the low 100s 10 years ago. That's a new strategy I'm suggesting in the marketplace for that. I think what we have to do, though, is we have to make some decisions. One, if these are basically drugs that are derived from the orphan drug program, and if there are federal dollars that were involved in the original research that led to the discovery of the drug, perhaps there should be some limit to what the drug can cost if you have contribution from the taxpayer for the drugs. I think we have to look at that kind of social policy issues. That's beyond this room, but it is a legislative question. And it really rises the tip of the spear for this whole issue of the cost. These are new issues. For instance, the hepatitis C drugs, the cost that you're quoting, 100 to 110 or down to maybe 80,000, is based on the manufacturers saying they need to recover their development costs and saying that it's cheaper than a liver transplant, which probably is. The question is, how many hepatitis C's go to liver transplant? And every hepatitis C gets the drug, so hard to say what the equation should be. So if you want something that makes a little difference before you make big change about how much a drug could legally be charged for, do things like use first-line drugs first, reserve the expensive drugs for second-line treatment, and use the correct weight whenever doing weight-based dosing, so you don't give too much of a $1,000 milligram medicine. And Angelo checked for genetic markers when they had ones that work, for instance, breast cancer with the tumor markers. And then do a complete course of therapy. For hepatitis C, you'll go halfway and have to start and go all the way, which is 1.5 times your 80,000 instead of just 80,000. Then another big societal question would be, who do you treat? A lot of that hepatitis C did not occur on the workplace. Some of the patients we've seen have been IV drug abusers who have hepatitis C, and their behavior that caused hepatitis C is not likely to change because they received an $80,000 medicine. So these are heavy lifting issues that are not something that doctors should just be deciding on their own. But I will tell you that if you expect doctors to be able to say no effectively to certain care, you've got to protect the no. We have to have societal policy in place and protection for doctors who say, no, this is just too expensive, we cannot do this for you.
Thank you. Hey, I think in the interest of time, we're going to go ahead and wrap up. Let me thank our panelists again.